I'm going to be talking about the fetal gastrointestinal tract, and we'll start at the level of the esophagus and work our way down the intestinal tract to the level of the colon. Beginning with the esophagus, a common ultrasound diagnosis is esophageal atresia, and this diagnosis is based on visualization of polyhydramnios in conjunction with non-visualization or small fetal stomach. So in this example here, we have polyhydramnios with inability to visualize the stomach in its expected location in the left upper quadrant on this left parasagittal scan and on this axial scan. However, gastric visualization does not rule out esophageal atresia. In fact, most fetuses with esophageal atresia have a tracheoesophageal fistula, and fluid traversing this fistula can be sufficient to allow visualization of the stomach. So this is a fetus with esophageal atresia and a tracheoesophageal fistula in whom we see a normal-sized stomach. Many times, though, in the setting of esophageal atresia and a tracheoesophageal fistula, the fluid traversing the fistula is sufficient to allow gastric visualization, but the stomach is not normal in size. And so this is a fetus with esophageal atresia and a tracheoesophageal fistula in whom we see a smaller than normal stomach on the left parasagittal scan and on the axial scan. This raises the question of what is too small for the stomach? Well, in actuality, usually this is a subjective call. In this particular fetus, you look at the stomach, it's slit-like, it's just simply too small. However, if there is any question about it, there have been several studies which have investigated the size of the stomach over gestation and resulted in the creation of nomograms of normal stomach size. And basically, these studies show that stomach size increases with advancing gestation. One of the more recent studies shows that, for example, early in the second trimester, at 13 to 15 weeks, the length of the stomach is 6 millimeters and the AP diameter and width approximately 4 millimeters on average. Whereas near term, at 37 to 39 weeks, the length of the stomach goes up to 30 millimeters and the width and the AP diameter of the stomach have also increased. Now, not so intuitively obvious, it is actually possible, although rare, to have gastric visualization in a fetus with esophageal atresia, but no tracheoesophageal fistula. And the explanation for this is thought to be that intrinsic gastric secretions are still occurring and cause distension of the stomach, allowing its visualization. Just like gastric visualization does not exclude the possibility of esophageal atresia, the opposite is also true. That is, non-visualization of the stomach or a small stomach does not always predict esophageal atresia, but rather can be seen in a variety of other etiologies listed here. We'll begin with oligohydramnios. In this pregnancy, you can see that there is a small stomach and there is severe oligohydramnios with only a tiny pocket of fluid. Oligohydramnios is actually a very common course for visualization of a smaller than expected stomach, and the reason for this in this situation is that there's very little amniotic fluid for the fetus to swallow, and since gastric visualization depends on swallowed amniotic fluid getting into the stomach will typically not distend normally. Non-visualization of the stomach can occasionally occur in normal fetuses, in which it typically occurs due to the unlucky event of imaging the region of the stomach during a period of physiologic gastric emptying. In this case, the non-visualization should be transient. Gastric emptying is a real phenomenon in the fetus. In fact, a study has been performed in which gastric size was measured every minute for a prolonged period of time on a large number of fetuses. And this study showed that gastric emptying can be detected by ultrasound as early as 12 weeks of gestation. Before 24 weeks, the changes in gastric size with cycles are smaller in amplitude, and the cycle length is quite variable, ranging from about 30 to 100 minutes. After 24 weeks, though, the cycles are more predictable, and by term, cycles stabilize at approximately 80 minutes. So it's not surprising then that in this fetus we cannot see the stomach in its expected location in the left upper quadrant at 12:06 p.m., but just 32 minutes later at 12:38 p.m. we see a normal appearing stomach, and this fetus is normal. Anything that can impair the swallowing mechanism can also result in a small or non-visualized stomach. That's because the fetus has to swallow to get the fluid into the stomach to allow its visualization. And so central nervous system abnormalities, neuromuscular abnormalities, and large facial clefts can all be associated with non-visualization of the stomach or a smaller than expected stomach. As an example, this fetus that has a very small stomach had this as a result of this large facial cleft that we see on 3D ultrasound. Finally, the stomach may not be visualized in its expected position in the left upper quadrant because it is not in this position, as can be seen with fetuses with diaphragmatic defects and situs abnormalities. So in this fetus, the stomach is not seen in the left upper quadrant because it's not in the left upper quadrant. Rather, it is in the chest due to a congenital diaphragmatic hernia. A helpful finding to try to distinguish the fetuses with gastric non-visualization or a smaller than expected stomach on the basis of esophageal atresia from the very many other etiologies of non-visualization and small fetal stomach is to actually visualize a fluid-filled proximal esophageal pouch, and what you would be seeing is diagrammed here. Still on the subject of the fetal stomach, ultrasound sometimes detects small conglomerates of material in the stomach. These may look like little neoplasms, but they will not be neoplasms as they might be if you were looking at an adult patient. But rather, in the fetus, these conglomerates are usually aggregates of swallowed cells that have been sloughed from the fetal skin. And as such, they are usually a transient phenomenon, and they are most commonly seen in normal fetuses. So in the patient that we saw on the prior slide, 4 weeks later, we see that the stomach looks completely normal with no gastric pseudomass present. Since these gastric pseudomasses are due to cells in swallowed amniotic fluid, they are often seen in conjunction with prominent echoes in the amniotic fluid, as was the case with this fetus who had a gastric pseudomass and has lots of echoes within the amniotic fluid. In fact, echoes are so commonly seen in the stomach and in the amniotic fluid with current ultrasound equipment that they're typically considered within the range of normal and rarely are commented on. Although that is the case, I should point out, though, that they are seen with increased likelihood in fetuses with certain abnormalities, in particular in fetuses with bowel obstructions or ventral abdominal wall defects, likely due to slowed gastric transit. And with slowed transit through the gastrointestinal tract, things are more likely to sit in the stomach and conglomerate. This is an example of a fetus with a gastroschisis. We see the herniated bowel loops here, who also had a gastric pseudomass. The other clinical setting in which gastric pseudomasses are of increased likelihood to be seen is if there is blood in the amniotic cavity and the fetus swallows intraamniotic blood. And this can occur following amniocentesis with bleeding into the amniotic cavity following a placental abruption, or in the setting of a subchorionic hematoma, because they are often seen in association with leaking of blood into the amniotic cavity. So this fetus with a gastric pseudomass has it on the basis of a subchorionic hematoma, where we see the elevated amniochorionic membrane here. With that, we'll move a little further down the gastrointestinal tract to the small bowel and the peritoneal cavity. We'll start with the duodenum and focus on duodenal atresia and other duodenal obstructions. The ultrasound antenatal diagnosis of a duodenal obstruction is based on identification of polyhydramnios in conjunction with a fluid-filled double bubble sign. So in this fetus, we see mild polyhydramnios in association with a double bubble sign here. 2 bubbles within the fetal abdomen, one of which is the distended stomach and the other is the duodenal bulb. The duodenal bulb should not typically be fluid-filled at ultrasound in a normal fetus. It is seen typically in the mid-abdomen, just barely to the right of midline. The fetus on the right has much more marked polyhydramnios, but also has a double bubble sign, enlarged stomach, enlarged duodenal bulb. It's extremely important, if you are suspecting a double bubble sign, to try to demonstrate the connection between the stomach and the duodenum, which makes the sign specific for bowel obstruction. So here we have a double bubble sign, and on the right now we see the connection between the stomach and the duodenum across the pyloric channel. If you see a hugely dilated double bubble sign, consider the possibility, as we have here, of esophageal atresia combined with duodenal atresia. The reason this particular combination can give you some of the largest double bubble signs is that you get a blind loop of bowel when you have both esophageal atresia and duodenal atresia. But the bowel is still secretory, so it keeps secreting fluid into this blind loop that keeps getting larger and larger and larger. The double bubble sign can be a relatively late finding in gestation. That is, often it's not seen until the late 2nd trimester or the 3rd trimester. But even when the actual full-blown double bubble sign isn't seen, in some fetuses early on, you can see precursors to it. You may see increased amniotic fluid, as we see here, or a stomach that looks a little bit more prominent than one would expect, even though we don't see the double bubble sign. In this particular fetus, a few weeks later, there was a full-blown double bubble sign, and here we can see the connection between the stomach and the duodenal bulb. In the differential diagnosis for a double bubble sign, when you can't see the connection, are a wide variety of cysts within the fetal abdomen. They include choledochal cysts, hepatic cysts, omental cysts, ovarian cysts, duplication cysts, etc. In this particular case, we have the stomach here, and we have an extra bubble here in a really good location for the duodenal bulb, except that it did not connect to the stomach. And this is a choledochal cyst, which oftentimes does occur in the mid-abdomen just to the right of midline, as is the case in this fetus.